Good afternoon. Thank you again for the opportunity to present on ovulation induction protocols. To start off with, what is PCOS? PCOS was essentially first described in 1935 by Irving, Freyler, Stein, and Michael Leventhal. Hence, it's called Stein-Leventhal syndrome. And essentially, they described a condition of amenorrhea associated with polycystic ovaries. Now, it's important to note that this was one of the earliest defined female fertility conditions, and therefore one of the earliest medical fertility treatment, that's clomiphene, and one of the earliest surgical fertility treatment, that's ovarian wedge resection, were introduced for PCOS. So there's a lot of history behind PCOS, and it's one of the most common causes of fertility problems. It is the most common endocrinological condition causing fertility issues, and it's one of the most treatable fertility condition as well. Now, why does PCOS happen? It's because of an increased GnRH pulse frequency, and practically this leads to an increased amount of LH, particularly in the lean PCOS phenotype. And there's also recent data indicating that there is elevated kisspeptin levels, which in turn causes the increased GnRH pulse frequency. Now, there's also an increase in the amount of AMH. There's increased androgen, both in the bloodstream, measured as hyperandrogenism, and also manifested as symptoms of hyperandrogenemia, say hirsutism and acne. There is elevated insulin resistance alongside alterations in the endometrium. Now, there appear to be a variation in how these features are expressed in different populations. For example, in non-Caucasian populations, insulin resistance seems to be a greater problem, and androgen excess doesn't necessarily seem to be the same extent of problem. Whereas in Caucasian populations, the increased androgen can be frequently quite an issue. And one of the earlier studies here in Leeds indicated that a good proportion of women with PCOS present to the dermatologist rather than the gynecologist or the fertility specialist. The conventional triad of PCOS treatment in the latter half of the 20th century essentially consisted of clomiphene, gonadotrophins, and ovarian drilling. Now, before we talk about treatment, it's important to consider what we can do before treatment. And I would argue that health enhancement should actually be considered a first-line fertility therapy. Now, why would I say that? Because it gives a good chance of natural conception. There's no monitoring involved for lifestyle changes, no side effects, obviously. And that's obviously, if they do need for ovulation induction in the future, the fact they've had lifestyle changes increases their success rates. And importantly, from a holistic standpoint, it's important we not just treat the fertility issues, but also the long-term health risks. And these long-term health risks are obstructive sleep apnea, diabetes, hypertension, endometrial cancer, and lifestyle changes can help with reducing the impact of many of these risks. Now, coming to lifestyle changes, what about diet? Now, we recommend an energy deficit of around 30%, which practically means you reduce your daily intake by 500 to 750 kilocalories per day, or in other words, it equates to a daily intake of 1200 to 1500 kilocalories a day. And no dietary strategy appears superior to the other. The information on dietary changes is directly taken from the international consensus between SJ and ASRM, available at the Monash University. And the evidence that no dietary strategy is superior than the other was from a recent systematic review. Now, coming to exercise, this is recommended for all women with PCOS, regardless of their weight. So whether you're lean or overweight PCOS. So if you have a normal BMI, at least 150 minutes of moderate intensity exercise or 75 minutes of vigorous intensity exercise is recommended. Now, I'm frequently asked, what is moderate intensity and what is vigorous intensity? This depends on how much your heart rate is. So your maximal heart rate for your age is 220 minus your age. So for a 30-year-old person, the maximal heart rate is 190. If you reach around 40-50% of your maximal heart rate, so if you reach around 100 or 110, it is moderate intensity. If you reach around 75-80% of your maximal heart rate, so reaching around 160, 150, 160 beats per minute. If your heart rate, they're probably aging into vigorous intensity, the upper limit of heart rate. And this is the limits of heart rate limits of moderate and vigorous intensity. From a more practical perspective, in a mild intensity exercise, you're able to maintain full conversations with the person next to you. Moderate intensity, you can say a few words, but that's about it. Vigorous intensity, you're literally out of breath, so you won't be able to hold a conversation. If someone is overweight, the exercise recommendations are higher, obviously, and we recommend around 250 minutes of moderate intensity per week. Now, there is a Fit for Fertility study group. They have a Fit for Fertility study, which is a multi-center randomized controlled trial, which specifically assessing a lifestyle program targeting women with obesity and infertility. And the reason why I'm quoting this is they have actually a good set of recommendations about what patients from a practical perspective can do. And this might be worthwhile sharing to the patients who might be interested. And hopefully the results from this study will give us a good, robust data on the exact benefits of physical activity and lifestyle changes. Now, the question comes, do we offer bariatric surgery? If someone has PCOS with morbid obesity and nothing else seems to be working, perhaps worth considering. It's important to know that surgery is not without its risks. They should avoid pregnancy for 1 year, which is the period of maximal weight loss, and nutritional supplementation such as B12, folate, and iron is often needed because the surgery will impact in the absorption of these micronutrients. Now, coming to ovulation induction, the oral, so there are this medical and surgical ovulation induction. Medical ovulation induction, you have the oral agents as clomiphene and letrozole, and you have the injectable agents, which is gonadotropins. And surgical ovulation induction includes ovarian drilling. Now, clomiphene was the classical ovulation induction. It was agent. It's a serendipitous discovery because it was used for endometrial cancer. And incidentally, it was found that these women had resumption of menstrual cycles. It was considered the gold standard till letrozole came around. And doses usually start from 50. Although in some women, if they're very sensitive, 50, 25 milligram has been used. I've seen it being used. And theoretically can go up to 200 milligram, but doses above 150 seldom are useful. So general rule of thumb I was taught when I was as a student was 50% of women will ovulate with 50 milligram, 75% with 100, and 87.5 with 150, and above that it's 93% with 200. It's a general rule of thumb, not an accurate statement, but goes to show that the sequential benefit, the additional benefit of doses above 150 milligram is not much. There was this very good paper looking at a normogram to predict the probability of live birth, taking into account features like free androgen index, the body mass index, whether they're oligomeric or amenorrheic, and you take all this into account and calculate the chance of ovulation, and based on the chance of ovulation and whether they are oligo or amenorrheic, you could predict the chance of live birth. It's quite good to be able to show people what the expected success rates will be, but it's important to note that this has not been extensively validated in other settings. What do we mean when clomiphene hasn't worked? And it's important we define certain terms here, because when we say unsuccessful treatment, it can mean different things, and the type of treatment which is appropriate might be quite different. If someone has clomiphene resistance, we mean they are not ovulating at all. And in that case, it is just reasonable to try other ovulation induction agents or adjuvants. Clomiphene failure, you mean they ovulate, but they're not getting pregnant. And that's a completely different ballgame because they are ovulating. In that case, do we need to check at whether the fallopian tubes are fine, whether the partner has had a sperm analysis? Ideally, this should have already been done, but if it's not been done or the reports are not available, worthwhile looking, or the reports are inconclusive, worthwhile looking at again. Now, letrozole has changed the entire picture with ovulation induction because it's now considered the first line. Letrozole was initially considered as an agent used second line if you have clomiphene resistance. But given that it's an oral agent, it has better success rate and doesn't have the negative effect on the endometrium. And given the Cochrane review has shown an increased live birth rate, it's reasonable to take into account the letrozole is nowadays considered the gold standard for ovulation induction. Interestingly, seems to be better for women with a high BMI. So maybe the normograms which I quoted here need to be revisited. And I would think that is a very good idea for a research topic. Someone was keen on looking at to develop a normogram for letrozole because currently there isn't one. Now, interestingly, it's one of the benefits of letrozole, which is often said, is it lowers the risk of multiple pregnancy. But interestingly, there was no difference in the multiple pregnancy rates in the Cochrane review. Makes me wonder whether, because it was in a trial setting, whether there were very strict threshold for cancellation in clomiphene, which, because a 2.2% multiple pregnancy rate for clomiphene is really, really good. It's a low multiple pregnancy rate. So but that was just an interesting sideline to the Cochrane review. Now, coming to the gonadotrophins, is considered as a second-line therapy in clomiphene resistance. Importantly, it's not useful in failure, but in resistance. Given letrozole, how good it is, it's less often needed now. Can start off at a low dose, 37.5 or 50 units, and then slowly increase the doses. And this was the conventional low-dose step-up protocol, increasing every 14 days, although I will come back to this. And the strict cancellation criteria, if there are more than 3 follicles over 14 millimeters, it's worthwhile stopping. Now, question is, when you tell about these multiple pregnancies, can you actually quantify the risk? And there's a very good article which I frequently use to counsel patients about what their risk of multiple pregnancy are. And you can take into account, and obviously the risk of multiple pregnancy for someone under 38 is not the same as a multiple pregnancy risk for someone 41 to 44, because the risk of pregnancy itself is lower. And so, you can take into account the age and the number of follicles, and you can counsel them what are the chances of them having a singleton, twin, triplet, or quadruplet pregnancy. And can we use gonadotrophin instead of ovulation induction, oral ovulation induction? This was a subject of a randomized trial. And interestingly, they found the cumulative live birth rate was actually slightly higher in women who had straightforward recombinant FSH rather than starting with clomiphene 50 and then going up to 150. But just to be clear, in my opinion, gonadotrophin should only be used if oral ovulation induction has not resulted in ovulation. But just to say there's been a trial on the subject. Now, what about ovarian drilling? Ovarian drilling is a refinement of the historical surgical wedge resection. My personal opinion, the only indication for ovarian drilling is resistance to oral ovulation induction. But frequently it is done opportunistically in case fallopian tube testing is needed for laparoscopy, or laparoscopy is needed for any reason at all. Then ovarian drilling can be done in conjunction, so that you are in that doing the laparoscopy anyway. Person has PCOS might not do ovarian drilling at the same time. The benefits, obviously, as a one-step treatment, you don't need any further monitoring for natural conception. My concerns with doing it opportunistically is around 10-20% of women can develop peri-ovarian adhesions. And given how good letrozole is in bringing about ovulation, whether ovarian drilling is still required to the same extent, I'm yet to be convinced of the data. And the other risk, especially as fertility specialists, is inadvertently there is a risk of reducing ovarian reserve. Now, if we compare ovarian drilling versus recombinant FSH or in clomiphene resistance patients, we find that the ovarian drilling alone, if you just use that, no other adjuvants, no ovulation induction afterwards, the cumulative clinical pregnancy rate in 6 months is 34%. Whereas obviously, if you use FSH injections, the cumulative clinical pregnancy rate is higher. However, after the 6 months, 54% of people require additional ovulation induction because ovulation did not assume. And the clinical pregnancy rate was actually 67% in the ovarian drilling arm as well, if we waited another 6 months. So the long-term success rate is probably not that different whether you go for ovarian drilling or FSH for women with clomiphene resistance. Now, comparing unilateral versus bilateral ovarian drilling, the Cochrane review found no difference in success rates. And in my mind, this could help minimize some of the risks with periovarian adhesions. Now, the general consensus is to be, if you're doing unilateral ovarian drilling, you drill the larger ovary, and some units only drill if the ovarian volume is more than 10 ml. And interestingly, ovulation often resumes in the non-drilled ovary, which indicates that the impact of ovarian drilling is not local, it's not to that ovary. It probably affects the entire hormonal ecosystem within a person. Now, coming to adjuvant ovulation induction, we have metformin or other oral hypoglycemics, Chinese herbal medicines, and acupuncture. Metformin is the most well-studied of the adjuvants. Used on its own, doesn't perform as well as clomiphene. It can help with clomiphene resistance. There is some data, there's actually reasonable data to say that if you use it long-term for women with PCOS, it can improve anthropometric measures. So basically, it changes their body fat proportion and things like that. So whether it should be used as a general health measure, we don't know. I don't think the data is there yet. But the one other question is, why do some women respond to metformin and some don't? There seems to be some sort of genetic variation behind this. Other oral hypoglycemic agents like thiazolidinediones doesn't seem to be as good as metformin. GLP-1 analogs might be a bit more effective, but they are more expensive and have more side effects. Coming to inositol and like myo-inositol, D-chiroinositol, it makes no difference as compared against metformin in head-to-head trials. It's more expensive, and therefore I don't think it's particularly useful unless someone is completely intolerant to metformin and they're keen to try some sort of alternative oral hypoglycemic agent. Now, I think metformin, it may be due for a comeback. There is a big trial in the US. This is not related to fertility. This is to do with aging and includes 3,000 individuals between the age of 65 to 79. It's going on 14 centers in the US and essentially looking at whether we can help with, I know the title is catchy, it says targeting aging, looking at whether metformin can reverse aging, but probably in my mind, at least, it seems to indicate that some of the long-term impacts of aging on the cardiovascular system and so on can be helped by metformin. So maybe if this trial shows a difference, we might be prescribing metformin for everyone. Now, coming to Chinese herbal medicines, a randomized controlled trial which looked at berberine, letrozole, and berberine plus letrozole, found the highest success rate was with letrozole and not with berberine plus letrozole. So in my mind, there's an additional reason why, even if you think intuitively something might work, there should be a randomized controlled trial before it's actually brought into clinical use. Important note, it was not statistically significant, but the numbers are a bit different. Coming to acupuncture, the Cochrane review in 2019 showed no improvement in pregnancy rates. IVF, obviously, should all else fail, IVF can be considered, and there is I can see there's an excellent talk subsequently, which talks about optimizing IVF for the high responder, which I'm sure we'll go through all of this in excellent and wonderful detail. To conclude, I would just like to signpost to the consensus algorithm for ovulation induction in PCOS, which was published in Human Reproduction a few years back. And this provides an excellent overview about how to start and initiate and monitor treatment for women with PCOS. And much of the information in this topic is derived from a book chapter in PCOS from Elsevier. And this is the book chapter itself, Targeting Infertility in PCOS. If your library has access to it, I would recommend having a look at it, because PCOS is much more than fertility. There are so many interwoven threads to PCOS, including long-term health and so forth. Thank you for your patient listening. Good afternoon.
Hello, Mariano, my dear friend. How are you? Thank you for this very nice presentation. You can hear me? Mariano, can you hear me? Can you open the mic? Open your mic.
Oh, sorry. Oh, sorry. Are you able to hear me now? Pardon me.
Oh.
Are you able to hear me now?
Mariano, how are you?
I'm good, thank you.
Yeah, thank you for this very nice presentation, which is comprehensive, actually. I will ask you a question, then I will leave questions for the audience. My question for you is, because we can see many of our patients coming to us with 6 or 7, 8 trials of ovulation induction, okay? And she's spending about 2 or 3 years doing ovulation induction. Afterwards, she got, unfortunately, premature ovarian insufficiency, and the patient coming to me with a problem in her ovarian response and ovarian reserve. My question for you is, you told us you are trying ovulation induction at first, and this is logic and accepted. If the patient was responding for ovulation induction, and you have got dominant follicle for something like 2 or 3 cycles, for how many cycles you are trying ovulation induction for the patient till having the decision of transferring or moving to the next step, which is assisted reproductive technology?
6 cycles of ovulation is worthwhile trying in the young woman and who has good ovarian reserve. 6 cycles of ovulation induction. And the reason for that is because the cumulative live birth rates are around about 30% after the first 2 cycles and reach around 50% by 6 cycles. After that, even if you wait another 6 cycles, the cumulative live birth rates probably reach only 70–80%. So 6 cycles of ovulation induction with the dominant follicles. 6
cycle ovulation induction only, or 3 cycle ovulation induction and another 3 cycles of IUI?
So the NICE guideline doesn't recommend IUI. And for that reason, here in clinical practice, we don't add in IUI generally. Now, there are 2 exceptions to that rule. Number 1, if you're having ovulation induction with gonadotrophins, obviously the cost expenditure is much more. So the relative value of adding IUI is different. So we have to take into account what is the cost. There are 2 factors here: cost-benefit analysis and invasiveness of the treatment and so forth. So if your ovulation induction with clomiphene is going to be not very expensive, whereas if you add an IUI, it becomes substantially more expensive. I would assume it at least doubles your cost. So are we going to double the success rate? Probably not. If it comes to gonadotrophins, then there is an argument to be made. Patient is paying a lot of money. Why don't we just add an IUI? But strictly speaking, from a medical standpoint, IUI is only indicated if the couple is having difficulties in sexual intercourse. It otherwise makes little to no difference.
Okay, thank you. Any question from the audience? Dr. Ashraf, Dr. Tariq, sorry, any question from to Dr. Mariano?
Thank you very much.
Any question from audience? Okay. Dr. Mariano, thank you very much for joining us in this meeting. And hopefully I will see you soon in our conference in 2023. Thank you very much, my dear friend.